Well, good afternoon. I hope you guys and girls had a great lunch. What I'd like to do over the next hour or so is go over what I believe to be the most important articles over the past 12 to 14 months. And I've tried to choose an assortment, but I chose them predominantly based on their potential clinical impact and their relevancy to the practice of emergency medicine in the streets by EMTs, paramedics, and every once in a while, nurses and physicians. Every once in a while, I'll pause for questions. If I could just request that you ask very easy ones and ones that I do know the answer to. All of these slides exactly are available as of today. If you Google me, you see that I work at Vanderbilt. And if you go to vanderbiltem.com, you'll go to the next heading, which says Conferences. You'll click that, and that'll drop down and just go to Conference Handouts, and then just pick the handout that applies to this talk. First topic deals with advanced life support drugs, ACLS. And I come from a generation where we gave calcium and bicarbonate and atropine and epi, and we debated the dose of epi. And so as ALS and BLS evolves, it's really interesting to watch whether it gets either more simple, usually, or more complicated. And so in the early 60s, Redding and Pearson clearly showed that epinephrine was the drug for cardiac arrest. Alpha vasoconstriction, beta stimulation of the myocardium, coursing the fibrillatory wave, awakening the heart from asystole, and making the conversion of PEA, at the time known as EMD, more likely. So this article ought to be heresy. Does epinephrine have benefit during CPR? This is a Japanese, yikes, this is a Japanese study. It is retrospective. It's not a prospective trial. And what they did is they paired patients who were equal as far as out-of-hospital arrest characteristics, downtime, rhythm, bystander CPR or not, time in minutes till EMS got there. And they went ahead and looked at epi versus no epi. Parenthetically, about 17% of the people in VFVT got epinephrine, about 14% of asystole and PEA. You see their survival up there, 26% for VFVT, and intact neurologically, 17.6. The reason the Japanese were able to do this study is that many of their responses are basic and may not have epinephrine but get the same exact care as far as defibrillation. This is what they found. Survival with no epi was 13.4, and survival with epi was better at 17%. However, when they looked at neuro-intact survival, they were exactly equal. There was no benefit to giving epinephrine as far as hospital discharge neurologically intact. Exactly the same. When they did the same comparisons in almost 10,000 patients, epi versus no epi, this is for asystole and PEA, survival was better with epi. But when they went to neurologically intact survival, although there was a 0.3% absolute difference, statistically there was no statistical difference. And so what these authors say is the following. Our study shows some favorable effects to pre-hospital epi. The absolute increase in neurologically intact survival, however, was minimal. And I really agree. Based on this study, it's hard to show a really significant benefit to epinephrine. I obviously still give it. You can be arrested and thrown in jail if you don't give epi to a cardiac arrest, whether they need it or not, or whether it works or not. But epinephrine's exact role, based on the current available literature, epinephrine alone, 1 milligram Q3 minutes, it's not absolutely proven. We should still give it, but be aware, yeah, maybe it doesn't work. So this next study is very interesting. And this compares epinephrine to epinephrine plus vasopressin plus steroids. And this is a Greek study. It's 3 hospitals. It's ER, ICU, and ward patients, predominantly ICU, but some ER patients. This is not an EMS study. It is randomized. Last one was not. This is double-blinded. It is placebo-controlled, 268 patients. So the study protocol is it's 5 cycles of epinephrine Q3 minutes versus epinephrine Q3 minutes plus vasopressin plus 1 bolus of steroids. And so what they did every 3 minutes was gave, if the person didn't regain spontaneous circulation, is they went ahead and with the 1 milligram of epi that the control group was getting, they also gave 20, I'm going to hit this 5 more times and scare myself, and they gave them also 20 units of vasopressin. So if you had 5 cycles, you would get 100 of vasopressin, single bolus of steroids. So here is the survival with epinephrine. This is return of spontaneous circulation, taken asystole, VF, and PEA, 65.9%. 66% of patients had return of spontaneous circulation for 20 minutes or more, versus a statistically significant increase to 83.4% if they also got, with the epi, vasopressin and steroids. So return of spontaneous circulation, epi plus vasopressin plus steroids, yes. Then they looked at survival to discharge, because that's the real currency. Whether you get a pulse back or not is meaningless. During the 80s, we began to use much more aggressive dosing of epi, high-dose epi. We would give 10 milligrams, and we had a dramatic return in spontaneous circulation, a dramatic increase in hospital admissions, not one extra patient discharged. High-dose epi saves hearts, but high-dose epi alone doesn't save heads. So this is regular dose epi, 5.1% discharged. Discharged neurologically able to either be relatively normal or at least care for themselves. And then look at this. If you added vasopressin, you essentially tripled the likelihood of leaving the hospital intact neurologically, or at least able to care for yourself. A dramatic and statistically significant increase in the likelihood that you would be discharged. There is no pre-hospital study looking at this that I'm aware of. This is the only current study. And what the authors suggest is the following. Vasopressin plus epi helps the CNS microcirculation. Epi alone decreases cerebral blood flow at the microcirculatory level because of its vasoconstrictor effects. Vasopressin appears to attenuate this, and perhaps steroids even enhance vasopressin's effects. The steroid group did get stress dose steroids, and of note, even the patients in shock did better with this 3-drug protocol. This study is not a definitive study. It's a single study. There was more PEA, which is more likely to respond in the triple group of vasopressin, steroids, and epinephrine. There's more asystole who are likely permanently dead in the epi alone group. Having said that, this is a very interesting study. Vasopressin plus epi plus steroids has potential. It may be worth trying. It certainly didn't hurt. So we'll see what happens. I'm not aware of anyone currently doing this. So now that I'm talking about supplementing epi, it seems only fitting that a drug from the 80s gets talked about. I do want to say this is from 2013, and this is a study that was done on patients from 1992 to 2008, retrospective study, and the question is, does prophylactic lidocaine, post-return of spontaneous circulation, have any benefit at all? And some of us were trained in the old days to use prophylactic lidocaine. It would decrease ventricular fibrillation. It turned out it didn't really affect how people did long-term, and there was toxicity of lidocaines, seizures and heart block. So prophylactic lidocaine went away. So here's the study, and this is from Seattle. I'm sorry about the feedback. It wasn't there a minute ago. Here's VF and VT. This is looking at repeat arrests. So these are people that have a pulse that now get put on lidocaine. And the question is, how are they going to do? So with lidocaine, the rearrest was 16.7% going into VFDT, and they had a 3.2% incidence of going into asystole or PEA. Matched controls. People that did not get lidocaine. With lidocaine, 16% rearrested. Without lidocaine, more than double. Statistically significant, P.0001. 37%, 1 in 3 went into VFVT. And look at this number as far as asystole and PEA, 3.2 with lidocaine, more than double at 7.8. Prophylactic lidocaine, post-return of spontaneous circulation in cardiac arrest victims in Seattle, did dramatically better. Now, it doesn't matter what happens. It matters who survives the discharge. Take a look at this difference. With lidocaine, 62% discharged. Without lidocaine, 44%. I don't know what to say other than we took lidocaine off of our ambulance units. We didn't use it. We're going to put it back on. Questions or comments?
Why doesn't AHA put it back in?
The question was, why doesn't AHA put it back in? Remember, the American Heart, I'm not on the committee, is evidence-based. This is a new study. Prior studies did not show much benefit to lidocaine. You were allowed to use it, it just wasn't first line. Amiodarone is first line. And when the first studies of amiodarone came out, amiodarone was really good. And this really teaches us an important lesson. And that is the following. Use new drugs as soon as possible before they either develop side effects or lose efficacy. I think this study will prompt more study. Lidocaine is very cheap. It either works or it doesn't, and it's relatively, if used correctly, non-toxic. As far as being non-toxic, 1.5 milligrams per kilo is a loading dose. It has about an 8-minute half-life. If you're going to push it, don't. Try to give it over about 15 seconds so that real peak blood level is not obtained, and that's where seizures are predominantly seen. All right, that's ALS. I want to move into BLS. So this is a classic, important, standard, good to have in the library kind of article. It's from Circulation. This is a consensus statement on basic life support. And I just highlighted some of the things. If you wanted to go to one article that has all of the new things, all of the current things, all the things we need to be teaching, this is it. Compress at least 2 inches. Allow full chest recoil. For non-mechanized CPR, 100 to 120 compressions per minute. Anything less or anything more will decrease cardiac output and survival. As far as breathing, 8 to 12 at the bottom end, 6 to 12 breaths per minute, lower, not higher tidal volumes. Our chest wall cavity is finite. The more air in there, the less blood that returns. The less blood that returns, the less goes to the coronary arteries and brain. Feedback is essential. And if you are not using a feedback system, it is unlikely that your men and women are doing high-quality CPR consistently. They may start out with high quality, but as they begin to tire, they won't appreciate it. In general, we feel like we're tired at about 4 minutes. In general, physiologically and performance-wise, we tire between 1 and 2 minutes into compressions. Team approach is essential, just like a pit crew, and avoid too many pulse checks. I'm going to talk about perishock pauses, and you really, I trained at a time that the reason we trained, I started out in Atlanta, the reason we began to have paramedics was so they could intubate. That was the reason to have a paramedic, intubate and defibrillation. Well, now an AED can defibrillate without even any EMS certification. And you don't have to put down an endotracheal tube to secure the airway. The supraglottic works very quickly. How have these changes that I just talked about affected survival? This is from Fiona Moore and her colleagues, London Ambulance Service, 8.2 million people, 70 ambulances. This is the statistics for witnessed VFVT, pre and post the changes. 2007, 12% survival. 2012, 32% survival. Almost a tripling in survival, just following the newer recommendations. Breathing less, pumping better, etc. This is discharge, I'm sorry. Survival to discharge, my apologies. The peri-shock pause is something we need to pay more and more attention to. So, how long from the time you stop CPR till you shock? How long from the time you shock till you re-begin CPR? The pre-shock pause, the post-shock pause, totaled the peri-shock pause. So this is from resuscitation. It's not yet published completely. The publication appears online. It'll be sometime in 2014 for the manuscript to be in resuscitation. So they looked at these intervals, and this is what they found. All right, it's up here. There's no way to hit it now. I can't hit it. So what they did is, in looking at these 2,000 patients, they went ahead and saw that 30% had a pre-shock pause of 20 seconds or more. Clear, please? Clear? Let's go ahead and charge it. Let me know when you're fully charged. All right, we're charged. I'm clear, you're clear, we're all clear. Everybody is clear. Okay, let's clear. Shock. So, you know, that's how you delay it. So the recommendation is that you need to be under 40 seconds and 20 seconds pre-shock wise. Well, their median time was 15. And so take a look at what it did. If you had a pre-shock pause of less than 10 seconds and you compared that to a greater than a 20-second pause, you increase survival by almost 50%. If you went ahead and shocked in under 10 seconds and compared that to the people that waited 20 or more seconds, it had an OR of 1.5. And so the key teaching of this article, the post-shock didn't seem to matter as much. The key teaching is that when you are going to defibrillate someone, you need to be ready to shock prior to stopping CPR. And so many systems, including my own, we say, go ahead and charge. We are not going to shock. Keep pumping. Okay, we're fully charged. When I tell you to, stop and come off and clear. Now, clear, fire. And we're back on the chest. And if you can get that down to as close to 0 as possible, or at least under 10 seconds, that's optimal. And the other thing is, I am not telling you to do it, but many people are doing hands-on CPR. And hands-on CPR, with or without gloves, is coming. It's clear that you can do it as long as you're well insulated. The original study used gloves. I've seen people, including on video in my own ED, because all of our resuscitations are videoed, who say, go ahead, I want to have it. And they feel a slight tingle or nothing at all. Eventually, we'll be doing more of that. All right, I want to move into mechanical CPR. How many people have mechanical CPR in their system? Okay. So mechanical CPR, I want to do the objective, not the subjective, and then I would welcome comments. All right. So first is a meta-analysis, 12 studies, critical care medicine this past year. 8 of them are the band distributing devices, 4 of them are the piston devices. And here we see piston device, mechanical CPR. They did not find that mechanical CPR with a piston-driven device in these 4 studies was superior. As far as the load band distribution system with more of a vest-like compression, they did find that to be superior. These are meta-analyses, these are multiple small studies, these are 8 studies. And so what they conclude is that load-bearing devices appear significantly better than piston-driven devices, but the robustness of these findings and long-term outcome should be tested in large, randomized, controlled clinical trials. And obviously, I agree with that. So, here is a large trial, just published, JAMA Online, November 17th. It will be in full print in 2014. Is mechanical CPR superior to manual? This is the LINK trial. There's a multi-center European randomized trial, Sweden, Britain, Netherlands. 2,600 patients. And this is the Lucas device versus manual CPR. They looked at 4-hour survival. They looked at neuro outcomes. Patients were randomized on scene. And so they either got manual or manual flipped into mechanical as soon as they can. And what they did, one of the beauties of mechanical, as you know, is that you can shock while the machine is firing. There's no perishock pause. 0.0 pre, 0.0 post-shock. So it has great advantage. And they would do cycles that were 3 minutes rather than 2. They shocked 90 seconds into the cycle if the patient was in VF or VT. And here's what they found. This is 4-hour survival and CPC score of 1 or 2, meaning totally independent, either normal, close to normal, or at least could perform activities of daily living. And with manual, 23.7% survival, 4 hours, and discharge, 6.4% CPC good scores. Then they compared that to the mechanical. 23.7 versus 23.6, obviously about as close as you can be without being exactly the same. CPC, 6.4 versus 7.5%, and that was not statistically significant. There was no significant difference between high-quality manual CPR and mechanical CPR. As I said, this was the Lucas device. I am not saying that mechanical CPR does not have advantages in long transport time. I'm not saying it doesn't have advantages to being able to be performed during PCI, but in this out-of-hospital study, it did not confer any benefits. Questions? Comments? The question was, same as doing mechanical CPR in the back of an ambulance. I am not saying that. I don't think we should do a lot of CPR in the back of an ambulance. I don't think people in cardiac arrest in general should be transported. I think you ought to try to resuscitate them at the scene with the same drugs we have in the ED, with either mechanical or manual CPR in and after 10 to 20 minutes, depending on your service and the rhythm, depending on the patient's end-tidal CO2. Maybe it's time to stop CPR. I do think termination of resuscitation criteria are exceptional and are accurate 99.8 to 99.9% of the time. Other comments? Yes, ma'am.
lucas from manual as well as routine initial use of?
So the question is, should you routinely use the Lucas if you have it? And what about the initiation of the Lucas? One of the early criticisms of mechanical CPR, and one of the reasons that one of the early studies has been criticized, is it took them 3 to 4 minutes, up to 5 minutes, to convert from manual to Lucas, and there was no perfusion. So the compression fraction, whether you're using the Lucas device or not, or any mechanical CPR, you really need to be at 80% or above. And if you're going to stop CPR for a protracted period to put on a mechanical device that's not proven to improve survival, then I would say no. But most services that use mechanical CPR, that practice in a pit crew-like way, can get it on very quickly. Based on the available literature, though, it's hard to prove that it has a benefit. Now, if you're going to transport people, if you're going to take them to the PCI lab, if you're going to move them downstairs, absolutely. If you always work your arrest on scene and use termination of resuscitation protocol, then I don't know what to say. It's hard to prove that it works. But there are a lot of companies downstairs that could tell you why it does. Yes, sir.
What about systole and PEA rhythms? Any studies that show whether they have any benefit in there? Because one of the sales pitches is that you potentially could save patients that you normally wouldn't.
So the patients in this study were not all VFVT. They looked at asystole and PEA. And in subgroup analysis for the VFib-VTAC, the asystole, and the PEA, no subgroup analysis showed a benefit. Asystole, in general, dead people are dead, in general. Now, you got to make some caveats. If you're in VFib, you're in between alive and dead, and it's up to us to move you over to the live side. But asystole, the vast majority of people in asystole are going to be dead for a protracted period. In one study in a cemetery, 100% of the people buried there were in asystole. However, there are 1 to 1.5% of asystolic patients that come back. And in an in-hospital study a year and a half ago in the New England Journal, if you work those for about 20 minutes, they actually had the best survival. Then they didn't use end-tidal CO2, they didn't use echo, they just said, you need to go longer. The mechanical device is no better than pumping on someone's chest for asystole. Most people respond to oxygen in the first dose of epi that are going to respond to asystole, but you could go longer. The mechanical CPR won't give you an advantage. PEA is a different heterogeneous group. PEA can be sudden mucus plug, it can be a pulmonary embolus, it can be hemorrhage, it could be a tension pneumothorax. It's an eclectic group. But PEA after 10 to 15 minutes is very dead also. So those are my biases. The literature does not support in any subset that mechanical works better. And I want to be clear, there are 2 types of mechanical CPR. There's the piston-driven, which is the Lucas device and others. That's what was studied here. The non-piston, more vest-like device, the distribution band devices, I am not talking about those. And the meta-analysis showed that those, in fact, did improve survival. There's not yet a very large study that evaluated it, though. Any other questions? So this is expensive. It's a major cost to an EMS system. More studies will come out. Just be careful as you make decisions. You know, you shouldn't ever buy insurance just because one insurance agent tells you ought to do it. You shouldn't use one drug because one study or one drug sales person tells you how good it is. And similarly, not all new EMS devices are that good. I come from an era where all EMS units were required by state law to have mask trousers. And early studies showed mask trousers were one of the best things in the world. And we know that they're not so much, and they can actually cause harm. tourniquets used to be dangerous, and now they save lives. We used to use an esophageal obturator airway if you couldn't intubate, which was really good, especially if you wanted to perforate the esophagus. We used to give glucose to all cardiac arrests because glucose helps the brain, and now we know it hurts it. So I don't know what to tell you about mechanical CPR other than the data is having trouble in the piston-driven devices proving they have a dramatic or significant benefit. They may, but these studies don't show it. Certainly if you're going to transport, pumping on somebody in the back of a moving ambulance might be a crowd pleaser, but it doesn't help the patient's coronary artery perfusion or brain. And it's really dangerous when you're in an accident. It's almost like you're on a motorcycle being ejected, but now you have metal walls to crash into. All right. So no, the LINK study doesn't have the delayed times. The earlier study that didn't show a benefit had all the delays. And then in the LINK trial, they tried to avoid that by very rapid application of the device. So the earlier study was criticized for its methodology, yes. The LINK trial, which just came out, not criticized for its methodology. At least not criticized by me. All right, I want to just now I've said some negative things about mechanical CPR. I want to say something good about advances in CPR, and that is compression, decompression. This is the plunger device where the chest is actively pulled out, then actively compressed. But you get compression, decompression, you pull blood back in actively, and it uses an ITD so you don't hyperventilate or fill the lungs too quickly, because as you decompress, you want to pull blood back in. You don't want to just pull air back in and not allow enough venous return. This is 2,700 patients, 46 EMS agencies. It's a secondary analysis of the rescue trial. And this is what they found. Using standard CPR, this is survival to discharge, they had 10.1% survival to discharge. Survival to discharge with compression, decompression, and ITD, not so impressive, 11.8%. But wait, there's more. When you look at the currency, neurologically intact survival, there was a statistically significant increase from 5.7 to 7.9%. When you look at survival at 1 year, neurologically intact, 4.7 versus 6.4. If you use compression, decompression, you will improve survival to hospital discharge with a modified Rankin score, with someone who's neurologically intact, by 38%. A statistically significant difference, an OR of 1.42. Compression, decompression with the ITD works, or at least has worked in these studies. And so that is something to be optimistic about. At the present time, there's not a good compression, decompression mechanical device that generates the negative pressure like the device used here. And let me close this section by saying basic cardiac life support is getting more and more advanced, and advanced life support is getting more and more simplified. All right, as far as airways, just one quick thing. I don't know how many of you use SGAs or supraglottics, but this compared a supraglottic airway using the King LT compared to bag valve mask ventilation. This is not a real person study. This is a real mannequin study. And each of the EMTs had about a year experience. This is out of Canada. Time to compression about equal. First breath was faster with bag valve masks. You'd think that you just get the bag on, start bagging them versus putting down the SGA. But take a look at the compression fraction here. 82%. Remember, you want to get at least 80% compression fraction versus 70. If you had the bag valve mask, twice the number of interruptions, better compression fraction. With the SGA, less interruptions. And so this, to me, is just further support of not mandating just endotracheal intubation or bag valve mask. There is an intermediate way to do it. Basics and advanced can throw down a supraglottic of your choice quickly. And my bias is the king. In almost all services up until recently, getting the family away from the code, clearing the room, has been what's traditionally done. And in most emergency departments, if someone arrests, you clear the room. You don't want the family to see what you're doing. Well, this is a study that questions that. I know children's hospitals often will bring the parents in to see part of the code, to appreciate the finality and all that's been done to try to save their child's life. This is a study from France, and they went and looked to see, does having the family there make a difference as far as long-term trauma? That is, how many patients developed, not patients, how many family members developed post-traumatic stress disorder after watching their loved one have a cardiac arrest versus how many had PTSD if they weren't allowed to view the arrest but had a family member die. This is 570 relatives of patients. It's multi-center, it's randomized, it's done in France, predominantly in Paris, but a number of French EMS systems. If they viewed CPR, at 90 days, 27% of the family members had post-traumatic stress disorder, 1 in 4. If they were not allowed to view it, not allowed to see all that was being done, 37%. More patients, 1 in 3, rather than 27% or 1 in 4 developed it. And so what the authors conclude, and this is from the New England Journal, it's a well-done study, is it's not necessary to clear the room, that you have less anxiety, less depression, and less post-traumatic stress disorder if parents, relatives, significant others are allowed to view the cardiac arrest. And more emergency departments are having families present, maybe not at the beginning of the code, but at least during the code. Questions or comments on family presence? Now, there are some times where you need to just get the hell out of the house with the patient and put him in the ambulance and either start moving to the hospital or lock your doors. I'm not saying that family or bystanders always need to be involved. I am saying that most paramedics can decide whether the family is appropriate to be there. This is, now we're moving into acute myocardial infarction. This is a new update, circulation last year. It updates the 2004, 2007, and 2009 guidelines. I only want to talk about it how it applies to EMS. And in the new guidelines, D2B has been replaced by E2B. Door to balloon is the currency, and it's supposed to be under 90 minutes. And so whether the EMS transmitted the ECG or not, in the old days, door to balloon began at the emergency department's door. That's how it became D2B. Well, now you can call it D2B, but it's E2B. And what I mean by that is first medical contact of that individual who can perform a 12-lead ECG to diagnose an acute myocardial infarction, ST elevation. So if you are competent to do a 12-lead, then that is when the STEMI D2B time starts. So it's really E2B. It's when the EMS paramedic gets on the scene. And that has resulted in more hospitals being more friendly to more of us. Because, you know, it doesn't matter what the EMS people do, but when they get to the hospital, man, we're going to rush. Well, now, if they don't activate based in coordination with what you're doing, they lose time. They will be audited, not when the person hit the hospital doors. It's going to be when that 12 lead was first done. And so if they don't do a pre-arrival alert, it's going to cost them 10 to 30 minutes. As far as how much time is saved as far as D2B or E2B if 12 leads are performed in the field, this is a really clean study that I just wanted to show. It's from Singapore. It's a before and after. With no EMS ECG, their door-to-balloon time was 75 minutes, went down to 51 minutes with 12 leads in the field and pre-alerts. Huge time savings, somewhere between 20 and 30 minutes. Here, 18 to 27 minutes time saved. So D2B or E2B, pre-hospital ECG, save 20 to 30 minutes. It is a American Heart Association, American College of Cardiology, Class 1 recommendation. D2B is now E2B. As far as pre-hospital ECGs, one of the biggest complaints my paramedics give me is at some of the hospitals, when they arrive there, the ER doc or docette does not look at their 12 lead, they look at the ED's 12 lead, the mark of excellence. And so, how often are STEMI patients' initial ECG non-diagnostic? And how often is the ECG in the field different than the ECG at the hospital? So first I want to do non-diagnostic ECGs, and that is, if a patient is having a STEMI, how often do they not have it on the initial ECG? So presenting ECGs, 89%. So in the ED or in EMS, only 90% of people that ultimately have a STEMI will have it on first ECG. Another 11% will have it after the first one. This is important to EMS for the following. Number one, if the EMS ECG doesn't show an MI, that's okay. It's used as a baseline to compare with the next ECG. Similarly, if they do have an MI there, it's possible that it may even change when they get to the ED. Patients with STEMIs or without STEMI on initial ECG are not different. Everyone should get more than one ECG if the first is non-diagnostic. My bias is, and I think the Bible actually says this, one ECG begets another. And I think it's actually in Genesis. You may not see it on first reading, but if you stare long enough, these words will appear to you. And if you don't believe in the Bible, then you should be thinking, if you get one ECG and it's not diagnostic, you should be getting another one. Just be aware, 1 in 10 STEMIs are not a STEMI on initial presentation. And now, in some way, a more important article for us in pre-hospital setting. And that is, if the pre-hospital ECG shows a STEMI, it may not always show a STEMI on hospital arrival. And if they don't study the pre-hospital ECG, they are going to miss it. So, how often does the EMS ECG change ED management? How often are EMS ECGs gone, ECG abnormalities gone by arrival? It's a prospective study, 281 patients. So, here's an abnormal EMS ECG, but a normal ED ECG. 12.5% of the time, the EMS ECG is abnormal, but by the time the person gets to the hospital, having gotten pain medication, having gotten maybe nitro, having aspirin on board, or just having spontaneous changes in the ECG, 12.9%, almost 13, 12.5%, almost 13% of people will revert to normal. And these abnormal EMS ECGs, which are normal on ED arrival, change management about 2/3 of the time, knowing that the EMS ECG was abnormal. As far as what goes away, ST depression, T-wave inversion, and ST elevation. STEMI on EMS ECG, gone by the time the patient arrives. Changes management 2/3 of the time. If you have a hospital that disregards your 12 leads, you should think about disregarding that hospital's ED. That's not a good place to bring your patients. Not because I'm an EMS kind of guy. I spend most of my time in an ED. But if they're not looking at the EMS ECG, not only is it disrespectful, it's bad medical care. More than 1 in 10 of those ECGs are going to have abnormalities that aren't available on the ED ECG, and if they looked at them 2/3 of the time, it would change patients' management. 12 leads are the standard of care in the pre-hospital arena if you have paramedics, and some people even have EMTs or EMTIs that do 12 leads. They're not expected to read them, but they're expected to do them. And I think I said this once before, I want to say it again. One ECG begets another. Yes, sir?
Is there any data on how critical lead placement for precordial leads is in the accuracy of the 12 lead itself?
So the question was, is there data on the accuracy of lead placement? You can't compare the ED ECG to the EMS ECG if there's dramatic differences in lead placement. The limb leads are fine, but you know, comparing V4 when it's in the 5th intercostal space or 6th, or it's in the anterior axillary line doesn't work. I don't know of a good hospital versus EMS one. I do know that putting on a 12 lead is a technical skill, and paramedics ought to be able to do it damn good. But I don't know of a study that compares placement. Other questions? Yes, sir.
What's your feeling about right-sided and posterior?
So the question is, what about right-sided and posterior leads? Theoretically, they should be much better. It turns out in the few available studies, one done by Rob Zielinski, and also mentioned in the ACLS circulation thing, they don't add that much. They take time. They don't change management much. In the ED, I think it's fine to flip over and do a right-sided lead. If you wanted to teach your paramedic, if you believe in right-sided leads and you wanted to make it as easy as possible, if they just take the V4 and flip it over to the right side, V4R, they'll pick up about 80% of what a lot of right-side leads will do. But in general, they don't make a lot of difference. I'm not saying they're bad. I'm just not saying they don't make much of a difference. Yes, ma'am.
Speaking of lead placement, it's my understanding that it's not very common for pre-hospital leads to be compatible with ED. That seems like a simple solution as long as the initial...
So I hate questions like this. The question is, it does not appear that most ECG 12 lead connectors interface with the hospital's 12 lead connectors. And this is a question that just really pisses me off. Because what you're suggesting is that there be some unifying conference where they say all electric lamps will have the same plug-in to outlets so that you could buy a lamp at one store and it would be just like a lamp from another store and they both work in your house. What a stupid suggestion. So just because it would save money, because you wouldn't have to do another set of leads, just because it would rapidly allow you to get another 12 lead, just unplugging and replugging into the hospital's 12 lead system, and just because there'd be no change in lead placement, so that you really could compare absolutely accurately the pre-hospital, the in-hospital lead, you're suggesting we do that? Give me a break. That's like saying we shouldn't have drug shortages of things like normal saline or epinephrine. I didn't come here to take crap like this. No, they don't interface, and it's really unfortunate. Can I just ask a question? Are any of you hearing music? Thank God. So I come from a generation that did a lot of drugs before it was legal in Denver and stuff, and so I never know when I'm hearing stuff whether it's a drug flashback or not. Please.
You said the right-sided doesn't change the care, but if identified the right side, there wouldn't be an encouragement. We encourage our paramedic students to be cautious with nitrates and any vasodilators, preload, that whole story.
All right, so right-sided leads increase the diagnosis of posterior and RV infarcts. However, there's a significant increase in false positives, and the sensitivity and specificity, when you look at it, it just doesn't change care much. Having said that, if you have someone who has inferior changes, whether it's ST elevation or flip T waves, if you know they have inferior ischemia, about 1/3 of those people are having an RV infarct or RV ischemia, you should avoid nitrates. Nitrates decrease pain, they do not affect mortality. It's just doing the right-sided leads doesn't change that much what's going on. So do many of you bypass the ED and go straight to the cath lab? So this is a study that looks at it. This is from Mission Lifeline. This is 12,581 pre-hospital STEMIs, and they evaluated them for ED bypass. And what they found is about 10.5% bypassed the ED. And then they looked at them. If you bypass the ED, your E2B and D2B is shorter by 20 minutes. 20 minutes was lost going to the ED in this study. For the 90-minute E2B, it went from 53% up to 80%. So it significantly increased the number of people that got timely door-to-balloon or EMS to balloon times. And in the initial data cut, it statistically significantly decreased the likelihood of death. So based on this, if you're not bypassing the ED, it's illegal, immoral, inappropriate, and you're subject to fines pretty soon. However, when they did an adjustment for mortality, like they balanced the number of people in shock, they balanced the number of people that were having arrhythmias, etc., there was no change in mortality. And when they looked at when this occurred, it occurred in only a few hospitals and occurred predominantly during working hours. And so the takeaway from this is, yes, it does save 20 minutes, but the reason the guidelines don't formally endorse this and make it a recommendation and merely an option is that it's hard to prove across the board that it has benefit. It does increase false activations, and a number of unstable people can go to the cath lab. If you did this routinely, evenings and nights, you could have someone with an arrhythmia or cardiogenic shock with an EMT and a paramedic and maybe one nurse over in the cath lab waiting for the whole team. So if you have the right system and your cath lab is ready and you're sure the patient meets certain criteria, this is excellent. But unless the team all agrees, unless EMS, ED, and the cardiac cath lab are all attuned to this protocol, unless you have a patient that's relatively stable, I don't think it's such a great idea. But if you do it in the right people, it works and it saves time. Just got to make sure it's the right people. So during the day, our helicopter service with flight nurses in hemodynamically stable people goes directly to the cath lab, and it saves time. During the day, our paramedic system, and it's Nashville Fire, I'm one of its medical directors, they come to the ED prior to going to the cath lab just to ensure stability and for us to line that patient up. As far as post-arrest care, I really do want to talk about this, and I want to talk about it because therapeutic hypothermia is changing, and it's important that we be abreast of it. Therapeutic hypothermia, and this is from the guidelines, should be started as soon as possible for comatose STEMI patients and out-of-hospital arrest due to VF or VT. Therapeutic hypothermia absolutely indicated if someone's not awake, whether they're having a STEMI or they've been defibrillated in VF, VT, even if you don't see that. However, immediate PCI is indicated for all STEMI arrests. It doesn't say anything about VF or VT arrests. All right. So I want to talk about now therapeutic hypothermia and do a couple articles. The first one is a very important article, and it's from the New England Journal just a few months ago, and it's what temperature for therapeutic hypothermia. Some places have been doing it aggressively, some people haven't, but this is from 36 ICUs in Europe and Australia, and they looked at mortality and neuro outcome at 180 days. As you can see, 80% of the patients are VFVT, 20% are asystole and PEA, and you see the breakdown there. And they compared, it's not therapeutic hypothermia versus no hypothermia, it's traditional hypothermia, 32 to 33 degrees, versus a lot warmer, just a little bit below normal 37. They aimed for 36, but it's really 35 to 36. In both groups, nobody was allowed to get febrile. Obviously, they were either deeply hypothermic or a little bit hypothermic. Most of them were surface cooled, about a quarter had intravascular cooling. They stayed cooled for 28 hours, and then they rewarmed them at 0.5 degrees centigrade per hour. Everything is the same. First measured temperature, serum pH, serum lactate, what percent was in circulatory shock, what percent had STEMIs. Really well matched, really well done study. And this is what they found. For people that went down to 36 degrees, here's their survival. Here is poor neuro. For 33 degrees, here is survival, here is poor neuro. There is no difference at all between going deeply hypothermic and going minimally hypothermic. The future of deep therapeutic hypothermia, which is labor-intensive, is no longer proven. And what appears crucial is a little bit of hypothermia, but absolutely preventing hyperthermia. And the reason I bring that up is obviously in hypothermia, you don't get fever. In the comparisons before, it was hypothermia versus no thermia. In the no thermia group, people could spike fevers. And so maybe having a fever post-arrest is what's really bad. So future studies will continue. This is a well-done, not likely the final study, but it looks like 35-36 is what we're going to be using for hypothermia. Tagging along with that is an article directly applicable to EMS. How many of you are doing pre-hospital hypothermia, hypothermia in the field? And this is something that's been endorsed by a lot of people. A number of my good friends have been doing it. Brent Myers has been advocating this, and his program in Wake has been one of the leaders in this. This is an important trial. If you haven't seen it, it is in press from JAMA. Does pre-hospital therapeutic hypothermia have benefits? This is 1,400 patients, 1,359 patients. It is randomized. It is from the Mecca, King County, Washington, the Medic One system there. 583 patients with VF, 776 without VF. Almost all patients were cooled on arrival to the hospital also. So they went ahead and looked, what are the benefits of pre-hospital hypothermia? And theoretically, there are a number, because this inflammatory response, this free radical generation may be blunted if you can cool them quickly. They went ahead and used 2 liters of 4-degree centigrade lactated ringers. It dropped the core temperature down by 1.2 degrees. The EMS patients that then got to the hospital got cooled to 34 much quicker. They looked at mortality and neurostatus. Obviously, the people that got cooled also got paralyzed. So here we go. No EMS therapeutic hypothermia. As far as survival to discharge, 64% of people in VF got survival to discharge if they did not get therapeutic hypothermia until getting to the hospital. Non-VF, 16.3% survival to discharge. If they got EMS hypothermia, 64.3 versus 62.7, not significant. Non-VF, 16.3, 19.2, not significant. There was no significant benefit in doing therapeutic hypothermia in the field. What's worse, there were more rearrests in the therapeutic hypothermia group that got cooled in the field. There was more pulmonary edema in the EMS group that got cooled in the field. There was no difference in pressor use. At the present time, there is no study to show that therapeutic hypothermia has significant benefit if it's started in the field by EMS. It costs money, it's a lot of training, a lot of resources. It does not have proven benefit. In my opinion, this is a large and definitive study. Now, other services are going to publish their data, but based on the available literature, I don't see a benefit to pre-hospital therapeutic hypothermia. Questions or comments? Well, they couldn't cool people to a single temperature. What they did is they administered up to 2 liters of lactated ringers that was at 4 degrees, and on arrival to the ED, the core temperature of the patients that arrived was 1.2 degrees less than the people that did not get cooling. So if you assume 37 degrees is normal temperature, these people were down to about 35.8 on arrival in the ED, and they got cooled down to 33, 34 by about an hour quicker. Other questions? All right. So obviously there's not an audience response system, but if you could just think about this question. A 43-year-old man has a witness cardiac arrest. He gets bystander CPR. He's defibrillated by an AED. On arrival in the ED, he's comatose. The 12 lead shows no sign of a STEMI. Should he get therapeutic hypothermia? He's comatose. Should he go to the cardiac cath lab? He does not have a STEMI. Or should he get both? So, hypothermia, cath lab. Now remember the recommendations. The recommendations say if you have VF, VT, and or a STEMI, then you should get therapeutic hypothermia. It doesn't say if you have no STEMI that you should go to the cath lab. It says if you do have a STEMI, you should go to the cath lab. But any arrest patient should get cooled. So for sure this patient is an arrest patient who hasn't woken up. He should get therapeutic hypothermia. But based on the current recommendations, it's not mandated that he go to the lab. So I want to tell you about this study. This was published ahead of print in Resuscitation. It's 754 comatose patients, status post-arrest. VFVT got therapeutic hypothermia, and then they didn't necessarily have STEMI on EKG. These are people without STEMI on ECG. So they go to the cath lab, and if they go early, this is survival to discharge, 65.6%. So if you have VFVT but no STEMI on EKG, you went to the cath lab, 2/3 left the hospital, neurologically intact. If you went late to the cath lab, that number is 48%. And if you followed the current recommendations, which says you don't have to go, only 1 in 4 are going to leave the hospital. And so I want to tell you that although this recommendation, I'm sorry I'm going to have to back up, although this recommendation says immediate PCI for all STEMI patients, I believe this is going to change. It's not in the current recommendations, but it ought to be the same. Therapeutic hypothermia should be started for all comatose STEMI patients and all out-of-hospital VFVTs, and immediate PCI should be done in all comatose STEMI patients and all hospital VFVT patients, regardless of whether they're having a STEMI or not. Probably about 20 to 25% of patients with no ST elevation, status post-VFVT, are having a STEMI anyway if you take them to the cath lab. Questions or comments? Go to the cath lab more.
What was the breakdown between early and late cath lab, the time cutoff on that?
24 hours. Sorry.
And what were the findings in the cath lab?
Do I have that here? Sorry. 26.6% had an acute coronary lesion. And that's consistent in multiple studies. Between 20 and 34% of people with no STEMI on ECG, status post-VFVT arrest, will have an acutely balloonable lesion. So why did we build cath labs? We built them to support the car industry, Mercedes, Audi, BMW, Porsche. We built them to support cardiologists. But one of the downstream effects is helping a hell of a lot of patients. Cath labs are maybe overused for patients with chest pain and people with stable coronary disease. But cath labs are not overused if you have a cardiac arrest. That's the beauty of a cath lab. If any of the cardiologists are in the room and I offend you, please, I have enemies wherever I go, and this ain't going to change my life. All right, so this is what I think. VFVT in awake, PCI. VF and VT in coma, PCI plus therapeutic hypothermia. We'll finish shortly. Is oxygen dangerous? This is the stupidest thing I ever heard of. This is what I taught for years. Intubate, oxygenate, and hyperventilate. Well, then the hyperventilation went away, and now the oxygenation and intubation are going away too. I'm not going to go through these studies. They look at cardiac arrest, they look at stroke, but this is what I want you to take home as far as oxygen. If you give somebody oxygen who needs it, great. But once that O2 sat is above 94, 95%, you ain't doing anybody any good. If their O2 sat is at 100%, the partial pressure of oxygen in their bloodstream can be well over 200 or 300. So when you look at hyperoxia, pressures of oxygen greater than 200 to 300, it causes vasoconstriction cerebrally, coronary vasoconstriction. It increases the risk for intubation. It decreases neurologic recovery post-CPR. It impairs O2 delivery, and it compromises hemodynamics. I really recommend this article. It's an easy-to-read article. These are the takeaways. 2 facts. 92 to 94% is what we should aim for on pulse ox. And in lungers, it's 89 to 92%. Too much oxygen is bad. Intubate, you don't have to anymore. Oxygenate, yeah, but not so much. Hyperventilate, no. 2 last things and we're done. Spinal immobilization. Everybody deserves to be on a long spine board unless you're driving the ambulance. And that's really how we've practiced EMS and pre-hospital care, and that's what we've done in the hospital too. So this is from 2013. This is an article to get. You know, I love when someone says, you ought to read this article, and it has a lot of basic science. It's 28 pages, and it has like 40 references and 11 different diagrams. This is a 2-page article. Read this article. It's from 2013, Pre-Hospital Emergency Care on Backboards. Here's from 99. These were the recommendations. Here's from 2013. These are the recommendations. Put someone on a long spine board, immobilize their C-spine if blunt trauma and altered mental status, spinal pain or tenderness, anatomic deformity, high-speed mechanism, not, you know, they got hit from behind at 10 miles an hour and they're outside the vehicle. High-speed mech plus drug or alcohol, inability to communicate, or they have a distracting injury. They got an open femur, they got a distracting injury. Don't use backboards if they have a normal mental status. They're not in severe pain. They don't have neural findings or complications. They don't have a distracting injury. They're not intoxicated. They're ambulatory at the scene and they have a little bit of neck pain and you want to put on a C-collar, great. Put on the C-collar, let them lay on the stretcher and secure them to the stretcher. Don't put them on a damn backboard. Get this article. It's 2 pages long. It rocks. As far as spinal immobilization, I just want to briefly mention this study. This is comparing the exact same kids who either get immobilized or not. I'm sorry, the exact same severity of illness, severity of mechanism, severity of pain initially in 285 kids. They have the exact same pediatric trauma scores, Glasgow coma scores. If they get immobilized, their pain score is 3. If they don't get immobilized, their pain score is 2. As far as imaging, if they're immobilized, 56% get imaged and 58% get discharged home. Now look at the same severity score if they don't get immobilized. If they don't get immobilized, 13% get imaged versus 56%. 3/4 less get imaged. They're not on a backboard, we don't have to x-ray them. Look at the difference in going home. Having a child spend a night in the hospital. If they get imaged, if they get immobilized, 58%. If they don't get immobilized, almost everybody goes home. Only 15% had to stay in the hospital. Immobilization is more than just immobilizing them in the ambulance. It means they're more likely to get x-rays, and little kids getting x-rays, not so good. And they're much more likely to get admitted to the hospital. So our mobilization in the field affects their care in the ED and their ultimate fate. I said that we'd finish by 2:45, and we're going to do it. This is a good article on anaphylaxis. It's a consensus from EMS physicians. Please remember that it's skin plus, remember it's a systemic reaction, respiratory symptoms, or reduced blood pressure. And a number of doctors, nurses, and paramedics forget that in kids, GI symptoms of vomiting and crampy abdominal pain. So if a kid has a rash and vomits after an exposure to an allergen, that's anaphylaxis. If a kid has a rash and crampy abdominal pain, that's anaphylaxis. And anaphylaxis equals epinephrine. And in a study that I'm not presenting because it's more than a year old, more than 50% of National Registry paramedics chose histamine as the first-line medication in anaphylaxis if it was mild anaphylaxis. The treatment of anaphylaxis, the national recommendation by the American Association of Allergy and Immunology is epinephrine, VFib, shock, hyper-K, EKG. Anaphylaxis, epi. One word, that's all you need to know. That's how I got into EMS and emergency medicine. I was trying to do medicine, they got a whole textbook, got flashcards in emergency medicine. Anaphylaxis, if the only thing you know is epi, you're in. 0.3 IM. All right, in summary, 2 sets of 5 and we're out of here. Consider vasopressin plus epi plus steroids. I'm not saying to do it, but please know that literature. And damn it, you got to reconsider lidocaine. It's coming back. We have to change how we do CPR and be up to national standards. 100 to 120, 2 inches, full recoil, minimize peri-shock interval, pit crew, don't hyperventilate. I don't know what to say about mechanical CPR, follow the literature. D2B is now E2B, and everyone needs to go to the cath lab whether they want to or not. Therapeutic hypothermia is warmer now, 35 to 36. Pre-hospital hypothermia is not supported in the literature. We've got to rethink immobilization. It affects care. And we have to especially rethink pediatric immobilization. The treatment of anaphylaxis is epinephrine 0.3 IM unless the person is in profound shock. Go to Vanderbilt EM and you can get the talk. It has been my pleasure. I only finished 2 minutes early. I apologize. Thank you all very much.